Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Hello and welcome back to the Teledyne Pulse. Well, Shane, here we are, episode 6 of considerations for your digital strategy. We're wrapping it up today to talk about results that some folks have seen as they've looked at all these factors.
Yeah, this is a fun one. I mean, these case studies are some of the fun. These are the fun things you get to do. Is in terms of working with an organization for a while up front, trying to figure out what would be the best for them, and figure out a game plan. You deploy the game plan, and then the game plan produces results.
Yep.
And in these two cases has produced some fantastic results.
Yep.
I'm so excited to share that a little bit with you in podcast land, and hopefully, give a little insight on how some of these programs can make a big difference.
Yeah,
and
for
again,
sure.
I want to emphasize we've had dozens and dozens of these types of success stories.
And this is just a couple.
These are just a couple of them that I think will be helpful for folks to hear about. And these are both critical access hospitals. Okay. And so we'll give a little bit of background on them as we get going here.
Yeah.
Yeah, so excited about this. I think this is going to be fun.
All right. So which one's the first one you want to talk about?
Well, we'll talk about this critical access hospital's in Nebraska, and this one is a population of about 10,000 people or thereabouts. Okay. And the primary service area is relatively small, and the secondary service area is relatively small, but they have on both directions within about 40 minutes to the east a large regional hospital and about 50 minutes to the west a large regional hospital. So they kind of sit in between two very large facilities. And when we started to talk with the CEO at this organization and just talking about, the initial part of the conversation, she thought they were transferring out too many patients, was just where this started.
Yeah.
And at the time, their average daily census was just over 2, like 2.2, 2.3. And when we got involved with them, part of the questions we were asking was just more surfaced around the emergency department structure. Is it an employed model? Are they locums, or is it contracted out third party? How's it structured? Is it physicians, APPs? Is it exclusively ED providers versus hospitalists versus local primary care doing the admissions? Who's doing the admissions, in other words? And what we found was it was a locums company, staffing company, providing care in the ED, and they were also assigned by doing the admission. So kind of like a quasi tuck and orders thing that's been around for a long time.
Yep. They
do the ED care, and then they do the inpatient admissions. And I think I've said this on a podcast before. I have several ED buddies. One of which who said, Shane, I'm an ED physician. I have ADD. I don't want to do this. Okay, I do my ED work. I got to move on to the next patient.
Yeah,
I'm this admission stuff. That's just not for me. I'm not into that. And so, what we found is a very low threshold to transfer.
Yeah,
the ED volumes had suffered a little bit, and
community perception again.
It is. I can't emphasize enough. If the community thinks they will be transferred from your facility, given a certain condition, they will drive to the hospital they think you will transfer them to.
Absolutely.
90% of the time. They just don't want to ride in the back of a bus.
Right.
Some enjoy it. Most don't.
Most don't.
And we also identified a pretty substantial number of outmigration of neurology and stroke patients as well. And so that, I won't belabor this too bad with a bunch of different discussion, but really that was the primary foundation of what we found as part of the initial analysis. And our objectives were to reduce the number of transfers out of the emergency department or increase the threshold to transfer. Our goal was to increase basically the average length not the average length of stay, but the census, the average daily census.
Average daily census, yep.
Increase the, of course, as a result, patient days. And we were going to increase. They also had a desire to build and grow a neurorehabilitation model in their hospital. So our goal is to increase the retention of neurology patients in general and stroke patients, and then increase the volumes within the neurorehabilitation center. They were also interested in obtaining stroke certification as part of this process. the local medical staff, when we started getting engaged with them and diving into some issues there on trying to really come up with the root cause of why the transfer threshold was so low and why the census was so low, and we came up with some interesting things there. And by and large, the medical staff was split, part employed by the facility, part private practice, which we run into that quite a bit, and really encouraged the hospital to take more of a hands-off, not really hands-off, but a voluntary approach, if you will, to a hospitalist strategy.
Yeah.
So, in short, what we came up with on the first two programs out of the gate was to start a virtual hospitalist program followed by acute neurostroke program. And the emergency department physician group that was there was they had to call the hospitalist group if they were going to potentially transfer, or call them obviously to do the admission.
Right.
So we transitioned the duties of inpatient admissions away from the ED provider, moved them to a virtual hospital.
Yes.
And we built that model where we had an APP that was doing the morning rounds and the morning activities and the daily admissions during the day. And at night, we would do all the admissions and cross-cover call at night. And the program went spectacularly well. And this was one of our first hospitalist
early
programs.
program.
Yeah.
Yep.
I mean, that program today is about 8 years old.
Yeah.
And it's still going strong across multiple programs they have running out there.
Yeah.
But so they that program has gone very well. I'll give you some numbers here in just a second. And from the neurostroke perspective, we also set some metrics as part of both those programs where we decided, we think based on the two programs, we can hit, so we should see somewhere of an average daily census somewhere around 6.5 to 7, maybe even 7.5.
Up from 2.
Up from 2, just over 2, which is, in terms of patient days, is a big deal.
That's a
We're
huge
talking
deal.
Big deal.
Yeah.
And in the end, today, where they're at is they're running census of around 10. Between 9.5 and in some cases 11.5. So, but they're hovering pretty consistently around that 10 range, and the program's just been spectacular. And as you look at the program launch that went into that, when we talked neuro and stroke, which is a key piece of this program, was how we launched both of those programs. And the grassroots effort required by the stroke neuro program launch, where we invited all the EMS agencies to the facility. Because, by the way, not only will your patients self-out-migrate, EMS agencies will encourage the patient just to go where they're going to have to transfer them anyway.
Because they don't want to make another stop.
They don't want to make another stop. So they'll encourage, if you will, the patient to go to a different direction, even though they're technically not supposed to do that. But we offered, it was a turnkey solution across all those programs, and assisted with the community engagement and rollout, of course, and went very well. And as a result of that, and based on the numbers we were forecasting for the neurostroke program, where we were going to see roughly 20 patients in the first year and within 12 months. And our goal was to retain 70% of those patients, which today we're at about 73% of all acute neurostroke patients, even in critical access hospitals, which would include post-TPA, post-TNCase patients.
Yep.
So as a result of this program, the first 6 months, we saw 22 patients in the first 6 months. Not year, but 6 months.
Yeah.
And so I'll stop there for just a second. One of the reasons why that's the case, based on analysis, and we've proven this out in a couple of other facilities, is the grassroots engagement with the area agencies. It increases your ED volume for those higher acuity patients that otherwise are driving.
And that's a critical key to success, is to engage those guys.
Totally.
Yeah.
Totally. Well, again, a lot of the conversations we've had with community members are very much along the lines of, I'll go there for a hangnail, or I'll go there. I mean, sometimes they're kind of sarcastic, but I'll go there if I hurt my elbow or I hurt my arm or whatever. But boy, if I got anything that's remotely close to being sick that I might have to be admitted for, I'm just going to go directly to X, because they're just going to transfer me anyway.
Yep.
So it's a big deal. You have to go and engage the community.
Yeah.
And so the CEO in particular has got to be out in front of people, talk about this constantly, to try and break that stereotype, if you will, may not even be a stereotype, maybe a legit type in terms of, the old adage of they're just a transfer center, an ambulance depot, whatever you want to call them. In this instance, we admitted 20 of the 22 patients to the facility, which is obviously in excess of 70%. And the two that were discharged, one was a hemorrhagic stroke that had to be transferred.
Yep.
And the other was actually discharged out of the emergency department. So of those acute neurological consultations, it produced a significant return on their investment, and not including the drive with some of the ancillary services. So basically by calculating patient days revenue that was subsequently gained, and after the cost of the program, they netted $180,000 just in the first 6 months.
And that's just patient days revenue.
After the cost of the program. That's after the cost.
Yeah.
That's their net.
Mm-hmm.
Which, by the way, the forecast, they would have admitted 1.5 of those 22 patients with their previous model.
Right.
So that's how you move census in the right direction.
Yeah.
In a hospital. And then, of course, the hospitalist on the back end has created a very seamless admission process. The satisfaction has been very high in that community with the virtual hospitalist program. And again, that hospitalist program's 8-ish years old and remains very strong out there.
It does, yeah. But, you look at that $182,000 positive return, and it's awesome, but it's also, you had 20 people who didn't have to leave town.
Oh, for sure. I mean, it's a big deal. You have 20 people. And then you think, now it's a big industry community where they have a couple packing plants and other industries there. And if you think about it, not only do they retain those patients, but they retain the productivity in the local workforce that doesn't have to take off work.
Family members can stay local.
To go drive to these other hospitals that they likely don't want to go to anyway.
Right.
So so for a community, for the community benefit, it's a big deal.
It is a big deal.
To those hospitals.
Yeah. Yep.
So that's case study number one. It's a fantastic study and again, that program still is going very strong. The next hospital we'll talk about is another critical access hospital. This was down in Missouri, and this is a little bit smaller community in terms of the primary service area, or the town of 4,500. And the secondary service area is a little bit larger, but similarly, they have a very large tertiary center. It's about an hour south of them, not quite an hour. And then they have 2 or 3 critical access hospitals within 30, 40 minutes of them.
Yep.
A couple of them are a little bit on the larger side. Beautiful brand new facility at the time. Again, this program's 6 years old or thereabouts. And what we found in that program was an employed emergency department provider model. And the complaint from administration coming in was more along the lines of, we're just transferring too many patients out. And we think that the local primary care base disagrees with that, but based on our emergency department employed physicians, they definitely think we're transferring out patients that don't need to go anywhere.
Got it.
So in working with the ED provider, the lead, the medical director, as well as the CEO, we, based on the data that we acquired, they were hemorrhaging patients, not transferred. They just were hemorrhaging patients down the road.
Yep.
And they also did have what also emerged from that data was neuro and stroke needs as well. And so their average daily census at the time was right around 2. In fact, there's days it was below 2. And they had, I would say, a local primary care base. None of the primary care base was employed. They were all private practice.
Got it.
And that ED model was the ED physician would call them to do the admission, and the patient would subsequently be transferred, is usually how it worked. And so we got involved, and the objectives really were we needed to increase their admission percentage. Similar to the last project, we needed to raise the threshold to transfer.
Yep.
And we wanted to, essentially reduce transfers and retain more neuro and stroke patients as well. So similar objective. Now, different structures around both those hospitals in terms of the ED and the needs around the ED and the primary care base, but similar objectives and goals, right? Again, their census right around 2. And we thought similarly we would target for an average daily census of, based on the data, somewhere around 6.5. And we wanted to increase the neuro and stroke admissions. Again, similarly, we wanted to exceed 70 or exceed 60% in terms of the admissions. For this project, we said 60%. Yeah. And they really had we had significant buy-in from the ED staff. They were great as part of this, and we had great buy-in from the nursing staff. Which, and again, I've said this 1,000 times on all of our podcasts. That the nursing is really the linchpin in these acute care programs.
They absolutely are.
The programs we decided to move in was again a nocturnal virtual hospitalist program and supporting a daytime APP on site who handled all the admissions during the day, as well as daytime rounding, as well as discharges, as well as cross-cover call during the day. We were there to be available to go in and see the patient with the APP and do oversight and sign subsequent orders as needed per Missouri law. And the program launch was a similar strategy here, too, where we deployed a community grassroots effort and assisting in that process of really engaging the community, because similarly, we found a dramatic shift in what they thought was a high-quality patient care scenario, which they were. Again, the patients that were taken care of, the scores were high.
The scores were great. Yeah.
What we did find, though, in that analysis was that patients weren't overly fond of the lack of care they were providing there when they really needed it.
Right.
And so there was a big-time effort to try and engage the community on, we're turning over a new leaf here. Give us another shot. You know, our goals keep you here no matter what.
Right.
We're bringing in additional specialists. We're bringing in a hospitalist now. We're ready to meet your needs and keep you right here at home with our new resources that are available. So it was a significant grassroots effort up front. And by the way, the pushback from the local medical staff on this was pretty impressive. I mean, the local medical staff was not terribly impressed with bringing this program in out of the gate. They felt they were, quote, taking care of all the patients that they should be, and really didn't think this was going to be valuable. Why were they going to spend money on this program?
Right. And
so the current average daily census is 10.5 to 11, up from 2 to 2.5. And the neurology retention was around, again, 74%, which was fantastic. And I want to emphasize probably the biggest shocker in this particular project, and we didn't have this for the first hospital at the time, but it was really the ED community perception study that we did there, where they really had a dramatic difference of opinion between the community thought of the hospital and what the hospital thought of the hospital.
Yes.
And I think that's the key. What the hospital thought of the hospital, or what the hospital thought the patients thought of the hospital, based on the data they had in front of them. But if you really peel the layers back with the population, they weren't huge fans.
Right.
A lot of frustration around, why are you transferring me so much, basically. And so this is why, as we saw an increase in our ED volumes by over 30%, which has been sustained for the last 3 years, is a shocking development. And with no change in population, no change in industry, no change in the demographics, no change in any, I mean, they had to have this influence of 3,000 new patients to the area. So exact same population, but yet their volumes increased by 30%. And the reason that happened was because, one, there's a strong grassroots effort by that administration to move that forward. It was great community engagement by not only the administration but the ED staff. It was a commitment to keep more patients there, direct engagement with the EMS agencies, and the willingness to go out on a limb and start this program against some of the medical staff's wishes. And again, keeping it voluntary, right?
Right.
Keeping it voluntary. And really moved it forward in a significant way where we're still seeing increased ED volumes of 30%. So not only do you got the patients that were showing up originally, they're being transferred, that you're now keeping a large percentage of, but then you have a whole new subset of patients you weren't seeing
that used to just
before.
Drive on by.
They used to just drive by. And you've captured those drive-bys, at least a decent percentage of them. And now you have them staying in your facility. So collectively, again, the program's netted them millions of dollars over the last 6-7 years. And similar to the first hospital, when we started with them, their top line budget was around $21, $22 million, and today's about $68 million. So and they would attribute a lot of that success to the virtual programs that they're offering there today.
Yep.
And when you get your census from 2 to, not everybody's going to get from 2 to 10 or 12 like these two have, but in a lot of cases you can dramatically increase it. Conservatively, odds are good you can hit it at least. If you're around 2, somewhere around 6 for sure.
Yeah.
So, and it doesn't take a lot of significant programmatic offerings to be able to do that. So the reason for these 2 case studies was really just to showcase as people have gone through this process and try to nail down what would make sense for us. And then we've actually identified this would make sense for you, identify where we think we can go with it, identify how to launch this, and build a little bit of a strategy behind how we're going to deploy this, and then see the results. It's pretty telling, really.
Yeah.
Folks that get involved in these processes.
Yeah, and it's not just about the numbers. Those are real people behind those numbers they're staying in their community. Their family members don't have to travel to go see them. It's just it's a community impact that goes well beyond just the numbers we're looking at.
Totally. And I think that what this CEO had mentioned to me was, he got caught in the store, and I think what surprised him the most was the conversations with family members that were just so appreciative that they didn't have to transfer their loved one to a different community. It wasn't the patient telling him, "Hey, thanks.
Right.
I'm glad I could stay here,"
spouse,
which they do. But it was the spouse,
the mom, the son,
kids,
the daughter,
the grandpa, grandma, whatever.
Yep.
It's so nice to just be able to stay home and go see patient X in the hospital here versus down in City X.
Yeah.
So it's a big deal, and I think the hospitals are starting to recognize that as they deploy more of these programs moving forward. But we've seen so many dramatic success stories. These 2 in particular were brought up as just case studies simply because they've kind of gone through that process with us over the years. And then this is where we went, and this is where they've gone, and they've just knocked it out of the park.
Yep.
And I can't emphasize enough in terms of the success of the program. It's a 2-way street on these programs. You don't just buy technology and have results like this.
No.
It kind of gets back to my conversation earlier in our episode 4.
Yeah.
Related, or 5 rather, with the technology. You can't just go buy technology, all of a sudden you get these results.
No.
That's not how it works.
It's hospital administration working, with the community, with the providers, the nursing staff, the whole gamut.
It's a whole gamut. It's all of those components which are mission critical. And having nursing staff teed up to do this well is mission critical.
Yep.
And then having the support through the system, and you have the technology that's good technology, that's reliable stuff that they know how to use. It's user friendly, and then you have the providers, and you have to have all of this, right? These things all have to be. You can't drop the ball in one of these areas, or you're going to struggle.
Yeah, absolutely.
You just will. And so that's why, as organizations looks at these types of models and thinks, "Gosh, we could just do this internally," and maybe you can. It's a matter of how much money you're going to spend, and then find out maybe we should just partner with somebody that can help us with this.
Yeah.
Right.
Yep.
But again, it's what I can tell you is if these are done and you hit all 3 of those components out of the park, you're going to drive success.
Yeah.
If you're doing it for the first time, you may fall down a few times. Like I still got scars on my knees, my head, my face from this, but really we've seen so many dramatic improvements in our rural hospitals. It's been amazing, really.
It really has.
It shocked me, actually.
It's satisfying to see stuff like this.
It really is.
Yeah.
And more importantly, the impact it has on the patient's family, and the community.
Yep, for sure. Well, this has been a great series, Shane. I would urge anybody listening to this episode, if you haven't gone back to episode 1 of the series, please do so. And Shane, this talk is something you've given in many different environments.
Yes, this is sort of a compilation of multiple. So, in essence, this is from a presentation that's been done either at national conferences or hospital association conferences or with individual hospitals that want to just get together and talk strategy around their virtual plans. Happy to do that, but it's been done multiple times and always goes very well. The conversations around these is so robust. It's just enjoy the heck out of it. It's just fascinating to listen to individuals who just want to make a difference, and they think maybe something here can help them. It's just great to help them with that. Try to develop some clarity around what they want to do.
Yeah.
That's all.
So if a hospital leader is listening to this and maybe they want to bring this to their hospital, they can reach out to us.
Absolutely.
Pulse at teledynehealth.com. We will get you in touch and talk about that. If you are part of a hospital association, want to do a presentation at a conference or something like that, we're happy to do those kinds of things too.
Absolutely. Look us up and reach out.
Yep.
Drop us a note. Drop us some feedback.
Yeah.
Rank the podcast. 10 stars, right? No, 5.
Yes. Five, I think, is as high as we can.
Yeah. And seriously, though, we're interested in any sort of feedback you have. It'd be great. And look forward to visiting with anybody that has an interest in these types of activities. So look forward to it.
Sounds great.
Awesome. Thanks, Andy.
Yep.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@teledigmhealth.com. For more information or general inquiries, please visit teledynehealth.com.